Teachers, friends, thank you for the kind words. I just realized the irony. I am walking here in slow motion and I am going to talk about speed in plastic surgery. But as they say in the Marines, slow is smooth and smooth is fast. So I'll just share some of the experiences of achieving speed in plastic surgery. That is based on my experiences from my teacher, Dr. Yogesh Bhatt, my learnings from my students, as well as my own personal experiences, as well as some review of literature. So why is length of surgery important? For patient, less anesthesia exposure means less anesthesia related complications, less nausea, easier extubation, less time in paralyzed position means less chances of neuropraxia, less chances of thromboembolism. It has been proved scientifically with numerous studies that less surgical site infections are seen when the duration of surgery is less. So that is one of the very important points from plastic surgery point of view. For surgeon practicing in the private sector, OT is charged by the hour, so less operative time means less charges to the patient and obviously more charges to the surgeon. For a surgeon in the public sector, we have limited OT days, so faster surgeries means more number of patients can be accommodated and operated. How long should surgeries ideally take? Ideal surgery should take as little time as possible to safely complete the task, and this should be done by choosing our time wisely, by deliberately focusing on the safety of the patient, and by continuous tissue respect, as we plastic surgeons all do. How can we become faster? So the most important thing I would like to highlight over here is speed is for the patient's benefit, not the surgeon's benefit. Speed gains come from efficiency and practice and not haste. I'll give you a couple of suggestions regarding how we can become faster and become more precise. Some of them are unorthodox. So most importantly is planning. I have found that visualizing the surgery beforehand and anticipating the problems increases your speed and precision significantly. It just takes 2 minutes of your time to visualize the actual surgery. What can be done pre-op should always be done pre-op. For example, while we are Dopplering a perforator, many times we do it in the theater, lot of time is wasted. There are anesthesia machines beeping around us, so that is also a disturbance. So these things can be done pre-op and should always be done pre-op. Always we should try and see the next several steps in our mind. For example, I would like to say my setup, which I believe would be same for all public sector setups. If I ask for a 3-0 ethylon, then the machinery starts moving, then the sister tries to go and locate the 3-0 ethylon, then there is no 3-0 ethylon with that particular needle. But if I have anticipated that particular instrument which I want, or that particular sutural material which I want, and I have told it beforehand a couple of minutes prior, then significant amount is saved. And these few seconds every here and there eventually takes a toll and it saves a lot of time. Identify steps which need time. Every procedure has got its own set of procedures. Every surgery has its own set of procedures which we need to give more time. For example, if we are doing the perforator flap, obviously dissecting the perforator is the area where more time should be given. Whereas if we are doing a fasciocutaneous flap, there is nothing in there which we are going to damage. We have to cut the skin, we have to cut the fascia, whatever cutaneous nerve we are going to encounter has to come with the flap. So obviously it shouldn't take more than 5 to 10 minutes of our time to harvest any fasciocutaneous flap anywhere in the body. So once we have marked it, that is a procedure which shouldn't take a lot of time. So we need to identify steps which need time and which need not. Many times we land up in problems intraoperatively, especially early on in the career. There is no point fiddling around at that point of time. We need to acknowledge that we are in a soup. We are not finding the solutions. We are not in a position to understand what to do next. We need to ask our friends, we need to ask our colleagues, we need to ask our teachers. And in the current technology, if no one is available to come in the OT and assist us, we can always have a video call, we can have a WhatsApp call, the problem is immediately solved, and then acknowledge, ask and act accordingly. It saves a lot of time and a lot of problems. Take advantage of enabling technologies. I am a strong proponent of using cautery directly for incising skin. I have realized that the blood loss is significantly lesser. The anatomical structures are very well identified. We get very good planes, and the scar, which is the main concern. The scar, as you can see, this is just one example. but we have been doing this for quite a long time. The scars are excellent, and there is significant amount of literature review which says that using cautery directly on a skin gives equally good scars as using a blade. Be ready with if-thens. So there are certain scenarios intraoperatively which keep on occurring on and off. If you are doing a perforator flap, if you don't find a good perforator, then what? If you find a peronia magna intraop, then what? If you accidentally perforate a rectum during vaginoplasty, then what? If you accidentally transect the greater palatine vessel when you are doing a palate, then what? So these are if-thens which we should be ready with. If we are ready with our if-thens, surgery becomes smooth, even life becomes smooth. So we should be aware with our if-thens. It saves a lot of time and outcomes are also significantly improved. Two-team approach. I believe this is a bit unorthodox and I am ready for breakbacks. In select cases, for example, if we are planning to do a groin flap, in those circumstances where the defect is not going to be significantly increased, we always plan the flap first, debridement and flap harvest go simultaneously. Lot of time is saved. If doing a burn contracture, releasing the neck contracture directly with the cautery and harvesting a skin graft always go hand in hand. We save a lot of time. We have an idea as to how much graft is required, and extra graft is never wasted. Be familiar with anatomy. Surgery, I believe, is like driving a car. In car we have clutch, brake, accelerator. In surgery we have cut, coag and suture. So if we are familiar with the road, we know where the speed breakers are, we know where the potholes are, we know where the schools are. So we are more efficient, we are more fast. Same is true with anatomy. If we are familiar with the anatomy of the region, our surgery is smooth, our surgery is fast, our surgery is efficient. So be familiar with your anatomy. How can we improve our efficiency and speed? The most important thing which I have realized is shoot yourself. Film yourself. So we can learn about what we do well and what we do not do well by watching our own surgeries, by watching us operate. And if we do that with a critical eye, I am sure we get a lot of insights on what we are doing right and what we are doing wrong, and we can improve a lot on it. Lot of videos are available on YouTube. Some are good, some are bad. We need to watch all of them with a critical eye and try to learn good things from each of the surgeries we operate, we see, and also identify the bad things that we don't want to do, like that particular surgeon has done. So to conclude, speed in surgery is a fruit of good technique, efficiency of motion and lack of complications. Few seconds saved here and there adds up to a lot of time. Lust for speed encourages risk taking, resulting in poor outcomes, longer surgery and poor complication. And this is the classic saying by Sir Harold Gillis: speed in surgery consists of not doing the same thing twice. Thank you.
Thank you very much, sir. Since we have a minute left, any questions for sir?
I have a question for sir. Here, on stage.
Oh, yeah.
So, I have always wondered, what do you use to film your surgeries? Because most of us will want to know that same.
Yeah, it's a team effort. It's our residents, and videos are shot in mobile, whichever mobile is free, either a Samsung or Apple or whatever thing. And the good thing about it is I have already instructed them that since I am operating, they need to stop me at any point of time when they see something extra in the field. There is extra gauze lying there, there is a bloody sort of drape over there. So it is their responsibility to stop me, to scold me, and that is why all our videos are good. It is entirely a team effort. Thank you.
Thank you, sir.
Thank you.